onto the intervention plan, given that they were unable to complete the OT evaluation, the additional information that would be needed is to assess for manual muscle testing, passive range of motion, and modified Ashworth scale. Then we created a problem list, first addressing patient education and safety, next ADLs, then sitting tolerance, functional mobility, and spasticity. We also would talk with Craig and his family to make sure that their wishes are incorporated into the intervention plan. The first long-term goal we would address is by the end of week 2, patient will demonstrate feeding with setup assistance. The second long-term goal is by the end of week 2, patient will tolerate supported sitting for 30 minutes. The third long-term goal is by the end of week 2, patient will demonstrate powered wheelchair mobility safely with independence. We created 4 short-term goals that aligns with each long-term goal. The first short-term goal is by the end of week 1, patient will demonstrate feeding with supervision. Second, by the end of week 1, patient will tolerate supported sitting for 20 minutes. The third short-term goal is by the end of week 1, patient will demonstrate powered wheelchair mobility safely with supervision. And the last one is by the end of week 1, patient will verbalize understanding of autonomic dysreflexia, pressure ulcers, and orthostatic hypotension. While working with Craig, he started to sweat and complain of pounding headaches and chills. This indicated that he has autonomic dysreflexia, and my response would be to place Craig in an upright position and remove anything restricted from his body, and also check his urinary catheter to make sure there aren't any kinks on it, and to continue to monitor his blood pressure. Later, Craig talks constantly about the day he will walk, and it motivates him to participate in OT sessions and gives him hope. To handle this, first, we would talk with the doctor about having a conversation with Craig and to explain to him about his status and his spinal cord injury. And during the OT session, I would be honest and open with him to not give him false hope, but also remind him of all the things that he's still capable of doing. Later, Craig has developed spasticity in his lower extremities and upper extremities, and he's anxious about this change. And he wants to have an explanation about this. So during the session, I would explain to him what spasticity is, and the presence of spasticity is typically normal in spinal cord injury, and explain to him that in the first 6 months, it increases and plateaus after about a year. Moderate spasticity can be helpful in treatment program to maintain muscle mass, assist in prevention of pressure ulcers, and assist in range of motion and bed mobility. One afternoon when we entered Craig's room, we find it filled with family members from both sides. And they have a small shrine set up, and they're involved in some sort of religious practice. Since the OT schedule is tight, this is the only time you have to see Craig this afternoon. The question was, what would we do? We would ask Craig and his family to educate us about the religious practice and ask if we can work with them during this time, and if he says no, we would come back another time during the same day to work with him. The last question asked us to write a discharge summary from acute care hospital. Since